I'm Dr. Fakir Ravani, and this is Clinical Microbiology, Susceptibility Testing, and Systematic Approach to Infectious Diseases. Here's an overview of the human immune system. We can think of the immune system as innate immunity and adaptive immunity. The components of innate immunity include physical and chemical barriers. So physical, you can think of the skin, which basically prevents pathogens from entering the body. And chemical barriers, you can think of components of the saliva, and perhaps most importantly, the gastric acids that basically kill pathogens. Other components of innate immunity include mucus, the complement system, and innate cells such as macrophages, dendritic cells, granulocytes, natural killer cells. In general, the innate immunity is non-specific or broadly specific molecular patterns. And the actual immune response is through cytokines and chemokines, which lead to inflammation, phagocytosis processes, the complement activation, as well as activation of effector cells. Now, innate immunity is extremely important because in healthy individuals with an intact immune system, many features constitutively are present. In other words, you don't really need prior infection or immunization in order to have innate immunity. And the response is immediate. So it takes typically minutes to hours for the innate immunity to kick in and fight infection. However, it only persists for a few days, so it doesn't really give you long-term protection or memory. That's where adaptive immunity comes in. So the components of adaptive immunity includes humoral immunity, such as B lymphocyte cells and antibodies, as well as cell-mediated immunity, such as T lymphocytes or T cells. So adaptive immunity is antigen specific to a given pathogen. So it's not very broad, it's very specific to specific infectious diseases. And the actual response is through activation, proliferation, and differentiation of antigen specific B and T lymphocytes. It involves secretion of antibodies that can fight pathogens, as well as effector activity of T lymphocytes, and of course generation of memory cells, which lead to long-term immunity. And these mechanisms get activated either through actual natural infection or through immunization. Now, the first time the body is exposed to a pathogen, the adaptive immunity will take several days to develop, and that's referred to as primary response. So primary is the first time the body sees that pathogen. However, once the immune system has adapted to that pathogen, the next time the body encounters that same pathogen, there will be a rapid response due to the memory that develops. So because of that, there is a long-term duration of adaptive immunity. Now, once the adaptive immunity clears an infection, there is a contraction after elimination of pathogens that typically happens in a few weeks after the infection is cleared. And what contraction means is essentially, through adaptive immunity, the body will develop a lot of antibodies. And then once the infection is cleared, these antibodies start to wear off. So the levels of antibodies after a few weeks go down to very low levels, and that's called contraction. However, because the memory cells remain, and there are memory B cells are the cells that make antibodies, so memory B cells will last months and years, and there are also memory T cells that will probably last for the entire lifetime. And so the next time the body is exposed to the pathogen, because of this long-term memory, the body is able to expand the antibody levels very quickly. Now let's take a look at the hematopoiesis process. We're not going to go into too much details on this. We just need to know what the end products are and what their roles are in the immune system. Of course, this all starts with the hematopoietic stem cells, and these stem cells essentially differentiate into different cells, and these are the cells that exist in the blood. So, in general, we have three different kinds of cells in blood. Of course, we have red blood cells. Red blood cells, another name for it is erythrocytes. We have platelets. Another name for platelets is thrombocytes. And then everything else that you see here are essentially white blood cells. And another word for white blood cells are leukocytes. So now, because white blood cells have an important role in fighting infections, we're going to go into more details of the different types of cells that constitute leukocytes. Essentially, anything on the right hand side on this pathway are lymphocytes. So we have B lymphocytes, we have T lymphocytes, and we have natural killer cells. And then everything to the left essentially comes from myeloid progenitor. So these are basophils, eosinophils, neutrophils, mast cells, and monocytes. Now, when we measure white blood cells in the blood, we typically count how many cells are in a microliter of blood. So, the normal range is anywhere between 4,000 to 11,000 cells per microliter. Now, if somebody has low levels of white blood cell, that's referred to as leukopenia. And of course, the other end is if somebody has too much white blood cell, it's referred to as leukocytosis. And that typically happens when people have an infection. Not every infection will lead to increased white blood cell, but if it is a type of infection that requires white blood cells to fight it, the body will start making more white blood cells. So, a typical sign of an infection would be if somebody has elevated white blood cell or, more appropriately called leukocytosis. And that would be if somebody has a level 12,000 or higher. Now, here on the right-hand side, you can see the shorthand way of writing some of these lab values. So on the left hand side is white blood cell, on the right hand side is platelet, at the top is hemoglobin, and at the bottom is hematocrit. And this is the shorthand when typically clinicians, when they work up patients, this is how they write. So you don't have to write white blood cell, you just write numbers here instead of these labels. And typically, if somebody says white blood cell is 4, they really mean 4,000. They're not going to write 4,000 or 5,000. So they typically write, like 6.2 or, 13. So if somebody writes 13 here, they really mean 13,000. Now, if you know somebody has leukopenia and they write 50 here, they're really talking about 50 cells. They're not going to write 0.050. So you just have to use it in the context. The same with platelets. So, typically people ignore the 3 zeros at the end. Now, hemoglobin and hematocrits are more straightforward. So the numbers are not too large. They're not in the thousands. So when somebody writes here hemoglobin is, 14, they actually mean 14. And hematocrit is in percentage, so that one is easy. Now let's take a look at the 6 basic types of leukocytes. So eosinophils constitute about 1 to 3% of all white blood cells. Basophils and mast cells, less than 1% of white blood cells. Neutrophils are extremely important. Neutrophils are the primary mechanism of fighting bacterial infection. So when it comes to bacteria, neutrophils have a primary role. And that's why you will see a large portion of white blood cells, typically 50 to 70% are neutrophils. Now, an important concept when it comes to neutrophil is the concept of segs and bands. So what we mean by segs or PMNs or polymorphonuclear leukocytes or just polys is that these are essentially mature neutrophils. And then the immature neutrophils are called bands, so band cells. And essentially, when the body makes new neutrophils, initially they are bands, and then it takes time for them to mature and become segs. So normally, most of the neutrophils circulating in blood are mature in the mature form, with the nucleus of the cell being divided or segmented. So that's where the name segs comes from. Now, during infection, because the body tries to make more neutrophils than usual, you will see an increase in the band or immature neutrophils, and that's typically referred to as bandemia or left shift. So left shift meaning the cells have shifted to the immature side. And so if you see more than 10% of the neutrophils in the band cell, that's typically called bandemia. So this percentage here is 3 to 5% of white blood cells are normally bands, and white blood cells, about half of them, 50 to 70% are white blood cells. So this 3 to 5%, you can think of it as typically 6 to 10% of neutrophils. So if you see more than 10% of neutrophils as bands, that's typically clinically significant. Now, other types of leukocytes include monocytes, and they actually progress to become macrophages, and those are 1 to 6% of white blood cells. And then we have lymphocytes and their derivative plasma cells, and a big portion of white blood cells are lymphocytes, and they have an important role in developing memory. But also they have a big role when it comes to viral infections, and of course they are also important in other types of infections, including bacterial and fungal infections. And lastly, we have dendritic cells, less than 1% of white blood cells. Now here are some more details about the function of each leukocyte type. In general, eosinophils have a role in allergic reactions, including allergic reaction to antimicrobial agents. They also have a role in fighting parasitic infections. Basophils and mast cells are also active during allergic response, especially anything with histamine release, and they have a role in inflammation. As I mentioned, neutrophils have a big role in bacterial infection, but they're also important in fungal infections. Macrophages are not only important in bacterial infections, but they're also antigen presenting cells, so they activate lymphocytes. And of course, the three types of lymphocytes. B lymphocytes are the ones that result in plasma cells that make antibodies. B lymphocytes themselves are also antigen presenting cells, so they can work with T cells. T cells, there are different types. There are CD4, CD8 that are most commonly important types of T lymphocytes. They are not only important in developing long-lasting memory to bacterial infections, but they also have an important role in fighting viral infections. We have natural killer cells, and lastly, we have dendritic cells that are also antigen presenting cells. Please pause this video and review the function of each of these leukocyte types. Now that we have a good foundation, let's take a look at our first learning objective. Given the results of a specimen stain, list the most likely organisms present in the specimen. And the specimen would be from the site of infection. So this could be blood. If somebody has infection in the blood, referred to as bacteremia, or could be urine or sputum or CSF or other types of specimen. Let's take a look at different types of bacteria. So in general, bacteria are divided into different groups based on how the cell wall is stained. So if you look at bacteria under microscope, you're not going to see anything because they're transparent. So in order to see them under microscope, we have to use some techniques to stain them so we can see them. If we look at bacterial cells, you will see inside the cell, there is a genetic material, and then the cell is surrounded by a cytoplasmic membrane or the cell membrane. And then what you will see outside of the cell membrane is a cell wall, which is essentially made of peptidoglycans for most of these bacteria. And that's what we stain. So we stain the cell wall, and the cell wall is what gives the shape of the bacteria. So they will have different shapes. So, either rod shaped or spiral or other shapes that we will talk about shortly. And one stain that we can use is called the Gram stain. So Gram was, is the name of the person who came up with the technique. And some of these bacteria, when you use the Gram stain, they will turn blue, and we call that Gram positive. So something that's particular about Gram positive is that they have the cell membrane, and then outside of the cell membrane they have a thick layer of peptidoglycan, and then this layer gets this is the cell wall that gets stained blue. And then we have another group of bacteria that are called Gram negative. These essentially stain pink using Gram staining. And something that's particular about the Gram negative is that they still have the cell membrane followed by a thin layer of peptidoglycan. And the reason this is thin is that on top of the peptidoglycan, there's a second outer membrane. So there are two membranes. So that's a major difference between Gram positive and Gram negative, that, Gram negatives have this outer membrane. So the peptidoglycan is thinner. And then we have a third group that just doesn't get stained using the Gram technique. So then we will have to use a different type of staining. So the acid-fast staining is used. A good example is mycobacteria. For example, if you think of tuberculosis. So these get stained with acid-fast. And then the fourth group is what we call atypical, because they do not have cell wall. So, they do not have peptidoglycan, because these three have peptidoglycan that can get, one way or another, they're going to get stained. But the atypicals, because they don't have a cell wall, they don't get stained. So, any of these techniques you use, they will not be stained. So these are atypical. So these are in general the four types of bacteria that are clinically important. Now let's take a look at some of these staining and microscopy techniques. So as I mentioned, the Gram stain is the most commonly used technique, and this technique can stain bacteria, but also some fungi species can also get stained. Certain bacteria, most importantly mycobacteria, do not get stained using Gram stain, so acid-fast is what we use. And then there are specific techniques that are used when it comes to different types of fungal species. Let's take a look at taxonomy of bacteria. So taxonomy is essentially the classification of organisms in an ordered system that indicates a natural relationship. You may be familiar with Linnean taxonomy, so that's the name of the person who came up with this system, which ranks organisms by domain, kingdom, phylum, class, order, family, genus, species, and subtype of species for some species. For example, E. coli, Escherichia coli, is classified here, and the most useful in general is the family, genus, and species. And occasionally, for example, when it comes to E. coli, it is useful to know the order as well. And the reason is there are a few clinically important organisms that belong to the family of Enterobacteriaceae, such as E. coli. And recently, some of them were reclassified to different families. So we used to refer to these by the family Enterobacteriaceae. And because some of them are no longer in this family, it is clinically useful to refer to them by the order Enterobacterialis. Now, a strain is a subgroup within the species that has unique characteristics that distinguishes it from other strains. For example, E. coli is the species, and E. coli O157H7 is one of the subtypes of E. coli, and that itself can have different strains. For example, these strains are identified by a sequence number. So that's an example of strains. Now let's take a look at some specific examples of Gram-positive bacteria. Now in general, whether it's Gram-positive or Gram-negative, these bacteria can be either aerobic or anaerobic. So essentially aerobic means that they require oxygen for replication, Anaerobic means that they can replicate in the absence of oxygen. And these definitions get more nuanced from a microbiology standpoint, but for us, clinically, that will suffice to distinguish between aerobic and anaerobic. And then with gram-positive specifically, we can look at morphology. So morphology is basically the shape of these and how they group together when you look at them under the microscope. So essentially, we can see cocci, and this is essentially in circular shape, and they can be in clusters. So cluster means that several of them are clustering together. And then you can have cocci, which is essentially circles in pairs or chains. So pairs will be a couple of them, and sometimes that's referred to as diplococci. And then, if you have a chain, they don't cluster. It's just, just like a chain. And then we have rod shape that are called bacillus, and the plural for it would be bacilli. And I should say cocci is a plural. The singular form is coccus. So if you're talking about the single bacterium, it will be a coccus. And then so for gram-positives that look like cocci in clusters, typically there's a test they do, then these tests catalase positive. And then on top of that, in the micro lab, they can do a coagulase test. And if you have coagulase positive, then you have a very important, clinically important organism, Staphylococcus aureus. Okay, and the reason we're talking about this is because it takes some time to identify what the organism is. And if somebody has an infection and we don't know what it is yet, but they look at it under the microscope and they say, well, it looks like cocci in clusters, and we also did a coagulase test and coagulase test was positive, as clinicians, we can anticipate Staphylococcus aureus, so we can give appropriate treatment. So that's why we're covering this. We're not trying to become microbiologists, but as clinicians, you can use this clinically to help patients. And if they say the coagulase is negative, you have several options, and together all of these are referred to as coagulase negative staph or coagulase negative staphylococcus. And there are several species that are coag negative, and I have listed 4 that are more common. And Staphylococcus lugdunensis is one that can cause severe infection, so that's why I have bolded it. But so these are typically present on the skin. The same with Staphylococcus aureus. All staphylococci are typically present on skin, and occasionally they find their way into the body and cause infection. And then for the catalase negative group, which they do not look like a cluster, so they will be in chain or maybe pairs. Then we can do the hemolysis test. So what a hemolysis test would be is that essentially an agar is essentially a plate. So what we do is that we use sheep blood, and we basically let these organisms grow and see what they do to the blood cells. So the beta hemolytic group, which you can see in this picture, essentially they lyse blood cells, so they will break it down and it will basically clear the blood, and that's called beta hemolytic strep. And the alpha essentially reduce hemoglobin, and they cause this greenish color. And then there is a third group that don't really do anything to the blood, and these are referred to as non-hemolytic because they didn't break it down. So essentially that's how we group these. So beta hemolytic strep, alpha hemolytic strep, and non-hemolytic. So in the beta hemolytic group, we have 2 important Streptococcus species. So Strep pyogenes, which is sometimes referred to as group A strep. And then we have Streptococcus agalactiae, which is referred to as group B strep. So these are important, and you should know these interchangeably, because sometimes people may refer to them as group B strep. So they might say, okay, for this patient, we are trying to cover group B strep. So you should know that they are referring to Streptococcus agalactiae. And if they say we want to cover group A strep, you should know they're talking about Streptococcus pyogenes. And then for the alpha hemolytic group, the most important is Streptococcus pneumoniae. This is very important because it causes respiratory infections, and we'll cover this in detail throughout the course. And then there's also the viridans group Streptococci. When this is group, there are multiple species, and there's really no need to know specific species. They're collectively referred to as viridans group Streptococci. And then the non-hemolytic, we have two Enterococcus. In the old days, these were also called Streptococcus, but nomenclature has changed over time. So nowadays, these are called Enterococcus, but they're also in the same group as the rest of the strep. Enterococcus faecalis and Enterococcus faecium, these are two organisms that are kind of the frenemy, so they sometimes they are good because they can be as part of the flora in the body and do some good, and sometimes they can be bad and they can cause an infection. So that's why they're tricky. So you have, and we'll cover this throughout the course. So sometimes, for example, they might be in the urine and prevent urinary tract infection. Other times they might be the cause of urinary infection. So it becomes tricky when we identify this in a specimen. So a lot of caution should be used. And then lastly, these are just the gram-positive bacilli, so Listeria, Bacillus anthracis, and Corynebacterium diphtheria. Now let's take a look at gram-negative bacteria, focusing on aerobic organisms first. When you look at the morphology under the microscope, first we're going to look at the bacilli. These are bacteria that look like rods under the microscope. And it is clinically helpful to break this into lactose fermenting organisms and non-lactose fermenting organisms. So specifically for lactose fermenters, we have Enterobacterialis, and this is a group of organisms that belong to the order Enterobacterialis, and pretty much all of these organisms were previously all part of the Enterobacteriaceae family, so we used to just refer to them as Enterobacteriaceae. But as I will show you on the next slide, is that members of Enterobacteriaceae were reclassified in different families. So now in the clinical world, at least, we refer to all these organisms, and there are more organisms than what's listed here, but we refer to them as Enterobacterialis or enteric organisms. And that includes E. coli, so Escherichia or Escherichia coli, Klebsiella species, Enterobacter cloaceae, Citrobacter species, Serratia species, Providentia species, and Protea species, among others. Then we have other members that are lactose fermenting. These are Aeromonas, Pasturella, and Vibrio species. And then on the other end of the spectrum, we have non-lactose fermenting organisms. And that includes Acinetobacter baumannii, Stenotrophomonas, Pseudomonas aeruginosa, and Burkholderia. And the reason this is clinically helpful, because when we have non-lactose fermenting, these organisms are highly capable of developing resistance to antibiotics. Specifically, Pseudomonas aeruginosa is a very virulent organism. So not only can it cause very severe infections, but it can also develop significant resistance to our antibiotics. Another significant organism here is Acinetobacter baumannii, which relative to Pseudomonas may be less virulent, so less likely to cause more severe infections, but still pretty capable of developing severe infections, but significantly more likely to have resistance compared to Pseudomonas. So these are very highly resistant organisms. Then we have cocci. So these are the ones that look like a circle or a ball under the microscope. We have Neisseria meningitidis, Neisseria gonorrhoeae, Haemophilus influenzae, and Moraxella catarrhalis. Of note, H. flu or Haemophilus influenzae and Moraxella catarrhalis or M. catarrhalis, these are coccobacilli. In other words, under the microscope, they kind of look somewhere between between cocci and bacilli. Then we have spirochetes. These are organisms that look like a spring under the microscope. That includes Treponema pallidum, which can cause syphilis, as well as Borrelia burgdorferi, which can cause Lyme disease. So here's the reclassification of Enterobacterialis, which occurred around 2020. So essentially, all of these organisms used to belong to the family Enterobacteriaceae, but then there's many of these which are clinically important were reclassified to other families, and there are more families than what's listed here under Enterobacterialis order. But as you can see, Morganella, Protease, Providentia, these are all clinically important because they can cause infection, and they were previously referred to as Enterobacteriaceae, but they're in a different family. The same with Serratia, Yersinia, as well as Hafnia. These are essentially are belonging to the order Enterobacterialis. And the reason it is clinically helpful to refer to these organisms as Enterobacterialis because they have similar characteristics. So for example, they can develop resistant to antibiotics, specifically by developing beta-lactamases, and because for the a large number of infections are treated with beta-lactams, it is helpful to know that organisms belonging to Enterobacterialis are capable of developing beta-lactamases, and we will discuss those in detail later. Now let's take a look at some anaerobes. So anaerobes, gram-positive is Peptostreptococcus, and then we have a series of Clostridium and Clostridioides difficile. So Clostridioides difficile also used to be called Clostridium difficile, and nomenclature changed a few years ago. And we will cover these later in the course. And the gram-negative anaerobes, essentially the most important you need to know is Bacteroides, because any intra-abdominal infection, Bacteroides have an important role. Atypical bacteria include chlamydia species, including chlamydia pneumoniae. That's not a sexually transmitted infection. It can cause, pneumonia. And then we have the sexually transmitted chlamydia. Also, we have Mycoplasma and Legionella. And then with the acid fast, we have Nocardia species, we have Mycobacteria, as well as Actinomyces. Looking at the results of a specimen stain, we listed the most likely organisms present in the specimen. Now let's describe the basic process of microbiology testing for identification and susceptibility. Let's take a look at the process of microbiology testing when a patient who's suspected to have an infection presents. So when the patient presents with symptoms and signs of an infection, we'll call this time 0. And typically, it will take anywhere between 1 to 3 hours for clinicians to examine the patient and, if necessary, collect specimens. And these specimens will be from the site of infection. For example, it could be blood or urine or any other specimen. And then the specimen will be sent to the lab, to the microbiology lab for testing. And what happens at the microbiology lab is that you typically have to incubate these specimens in order for bacteria to grow before we can detect anything. And this can be done using automated systems, or it can be done on an actual plate. So these plates are called agar plates. And what they are is that they essentially have nutrients in them for bacteria to grow, and you just let them sit there and incubate under the right temperature for bacteria to grow. And then after a while, typically anywhere between a few hours to a few days, depending on the organism, we may start to find colonies of the organism. Now, of course, it's possible that nothing may grow. So, sometimes it will be difficult to identify, but if there is a specific organism that will be identified, it will be growing typically between 12 hours to 5 days. And depending on what type of infection we are suspecting in the patient, if we think that it might be an organism that's a very slow grower, it will be wise to keep the specimen for beyond 5 days in order to give it enough time to grow. Now, if something does grow, that's when, typically they start to stain it and then look at it under the microscope. So while the process of staining, is not time consuming, now if you look at the entire process, it typically takes somewhere between, half a day to a day, if not more, before they can actually look at it, stain it, and identify, if it's bacterial infection, whether it's gram-positive, gram-negative, or atypical, and then look under microscope to look at morphology. And then there are a series of tests that will be done in the micro lab in order to identify. So this is where they do those, the lactase test and oxidase test and hemolysis test. And so there will be numerous tests that will be done if applicable, in order to actually identify what the exact organism is. And that typically takes anywhere between 1 to 2 days after staining. So now, this is typically day 2 since that patient presented at the minimum. And once an organism is identified, so for example, if they say this is E. coli, then the next step would be to identify antimicrobial susceptibility. So then, it typically takes another 24 to 48 hours to do various testing, and we will go over some of these susceptibility testing. But the key point here is that it will take, another day or two after the organism is identified in order to find susceptibility results. And what that means is that, they will tell you like which antibiotics will be active against this organism and which ones will not be active, so that we can streamline treatment. Now, as technology advances, we have rapid diagnostic tests that can expedite this process. So, when we actually grow an organism, we can directly put the some of these colonies into rapid diagnostic tests, and these rapid diagnostic tests will be able to very quickly, in a matter of anywhere between under an hour to just 2 or 3 hours, tell us exactly what the organism is and what the susceptibility results are. Now the problem is these diagnostic tests are limited to only a select few organisms, so they're not comprehensive of every possibility. So it's not a replacement for the traditional process. So even though we use a rapid diagnostic test, we still need to do the traditional identification and susceptibility testing, because in case the patient has an organism that is not included in this rapid diagnostic test, we still need to figure it out, and you don't want to slow down this process while the rapid diagnostic test is processing. But certainly these rapid diagnostic tests are advancing very quickly year after year. Now, what happens in parallel to this process is what we do to treat the patient, because we're not going to wait for this process to complete and then start treating the patient, because the patient could die by day 3 when we find out exactly what antibiotic will work. So what we do is initially we do empiric antimicrobial therapy. So what empiric means is that we don't really know what's causing the infection, but we will do our best guess to, based on the signs and symptoms, we can anticipate what organisms are possible, and we can use antibiotics broad enough to cover the possibilities. So now we can kind of look at the timeline of treatment. So we typically, we want to avoid treatment as soon as the patient arrives, because if you give the antibiotics immediately, you might not be able to identify anything because you kill all the organisms. So you want to get your samples first if possible, and then start treatment after you get the samples. And then, once we get rapid diagnostic results, that's your first opportunity to optimize treatment. So based on what you find, you may be able to change the antibiotics to have something that's better for the patient. The same with, when you have gram stain results, you can change the antibiotics. And ultimately, when antimicrobial susceptibility results are available, at that point, we will switch from empiric therapy to pathogen-directed therapy, meaning that we know exactly what is the best antibiotic for the patient that will be active against the organism and will be the narrowest that would get to the site of infection and will result in the optimal outcome for the patient. When it comes to phenotypic susceptibility testing, the concept of MIC is extremely important. So MIC stands for minimum inhibitory concentration, and it is the lowest concentration of an antibiotic that inhibits visible growth of a microorganism. And that's why, we say phenotype is what actually appears. So, it will be visible to the actual human eyes. And that's to distinguish it from genotypic susceptibility testing. So this is, regardless of what resistant genes may be present in an organism, the minimum inhibitory concentration just, shows you what's the minimum concentration to inhibit growth of organism. And there are different ways to measure MIC. So the gold standard is the broth microdilution, and by gold standard I mean this would be the reference method, and any other method would be something to as a surrogate for the broth microdilution. And here's how broth microdilution works. So you can kind of imagine a series of test tubes in the microbiology lab, and then in each test tube, we will have a broth. So what broth is essentially, nutrients for bacteria to growth. Now these are sterile, so there are no bacteria in them. And what we do is that we put antibiotic of choice that we are trying to test in these test tubes, and we increase the concentration of antibiotic in each test tube, so kind of double the dilution. So essentially one of them will not have any antibiotics, so the concentration would be 0, and then we kind of double the concentration in each test tube, and then we inoculate these test tubes with the organism that we are trying to test, and we let it grow. And then after the incubation period is over, we can see that it actually, the growth becomes visible. So you can see that it has become cloudy, or the color may have changed. And then you can see at what concentration nothing grew. So for example, in this example, you can see that at the concentration of 64 and above, nothing was growing. So the minimum concentration was needed to kill the organism in this example is 64, because a concentration of 32, the organism was growing in the test tube, but at 64 or higher, nothing was growing in the test tube. And that's how they measure the minimum inhibitory concentration for a specific antibiotic. And MICs, so every antibiotic has a different MIC for each organism that it covers. So if you have antibiotic A, it will have MIC for E. coli, let's say. It will also have a different MIC for Klebsiella, and so forth, if the antibiotic A is active against these organisms. And then the same when you go to a different antibiotic, you have to measure the MIC for that different antibiotic for each organism. Now, another method to do is disk diffusion, also referred to as Kirby-Bauer method. And the way this works is that essentially, instead of test tubes, which you can imagine that it will be very labor intensive, so broth microdilution takes a lot of space and requires a lot of labor, so it may not be feasible. And that's why we say it's a reference method. So a much more feasible method would be disk diffusion, and here's how it works. So instead of test tubes, you have an agar plate. So again, this plate is sterile. What's on the plate is nutrients for bacteria to grow, and what we do is that you inoculate the agar plate with the organism that we're trying to test, and then immediately after we inoculate the plate, we place several discs. So these discs are essentially different antibiotics. So each disc has a certain concentration of the antibiotic, and when you place these discs in the region near each disc, this antibiotic starts to diffuse, and the further you go from the center of the disc, the concentration drops. Okay, and then at some point when you go too far from that disc, that specific antibiotic may not be present. So each disc has a different antibiotics. So you are simultaneously testing multiple antibiotics for this particular organism. And then if you have multiple organisms, then you will have one plate for each organism. So you can have several plates set up. And then you let it grow. So after the incubation period, you kind of can see that there are there is essentially a lawn of the organism that grows, and if the organism is susceptible to that antibiotic, there will be a zone of inhibition. In other words, because antibiotics have diffused in this region, the organism will not be growing, and if it's resistant to it, you can see that the organism will grow through the disc. Essentially means that that antibiotic was not active. And then we can kind of correlate this to some, whether it's, is it really susceptible, or is there some sort of intermediate resistance going on? So we can measure the zone of inhibition. So you can see this is a circle. They can actually measure what's the diameter of this zone, because as you can see, some of them have a smaller diameter, others have larger diameter. So the larger the diameter means the more active the antibiotic is. And we'll talk about how to interpret this zone of inhibition shortly. And of course, if it goes through the disc, that means that the organism is completely resistant to that antibiotic. So that's disc diffusion. And then another method, disc diffusion only tells you if it's susceptible, intermediate, or resistant. It doesn't really give you MIC. Okay, so broth microdilution will give you MIC, and then based on the MIC, we can decide if an organism is susceptible, intermediate, or resistant to the given antibiotic. This diffusion only tells you if it's susceptible, intermediate, or resistant without the MIC. So another way to do it in order to get the MIC is the e-test. So the way e-test works is similar to disc diffusion. The difference is that instead of placing discs and then measuring the zone of inhibition, you put a test strip. So there is a strip that has a given antibiotic at different concentrations. So you can see that, at the top, it has a very high concentration of antibiotics, and the more you go down the strip, the concentration drops. And then, again, you inoculate the plate, you place the strip, and you let it incubate. And then after incubation, you can kind of see a zone of inhibition. And then you can see at what concentration the antibiotic stopped inhibiting growth. So that would be your MIC. So in this example, we can see that it stopped growing at concentration of 0.126 or higher. So the MIC would be that number, 0.126. So that's something that's also done in practice. And another way that's more commonly used is the automated machine. So there are certain machines that are automated, essentially. So you can see the one example in this picture where you essentially load this with your sample. You can test a lot of samples simultaneously. So there are these cartridges that you put in, and you just run the machine, and it may take some time for the machine to run. And then, in a matter of an hour or so, and then it will actually give you MICs. So then you can, get your MIC and interpret it as susceptible, intermediate, or resistant. And this is, these automated systems are most commonly used for majority of the samples. Now the issue is that because these machines are difficult to make, they typically come preloaded with certain antibiotics. So if a new antibiotic comes to the market, it may not be available in this machine, and that's where e-test comes in. So anytime a new antibiotic comes to the market, the manufacturers will make e-tests available so that micro labs can test for susceptibility so they can use the new antibiotic. And of course, new automated machines come to the market all the time. So here's an updated slide showing some examples. For example, Vitek 2, there is a Microscan, Phoenix M50, and Sensititer. Now, when you get your MIC results, or if you get results from this diffusion, what they really tell you is, those MICs are essentially in a test tube or on a plate, which we call in vitro, meaning it's not inside a living host. Although we know there is a minimum inhibitory concentration, that doesn't necessarily mean that we would be able to achieve that concentration inside the patient's body. So, it has to do with, the dosing of antibiotics that are safe. Would we be able to achieve that concentration in the patient's body? So in order to interpret that MICs and see if it's feasible to use that antibiotic, there are criteria. So, just knowing the MIC doesn't really tell you whether you can use it or not until you interpret it. And the way we interpret it is that we use CLSI is the organization that gives us the interpretive criteria or breakpoints for MICs. And and I will show you how to navigate this document, but essentially they will tell you for a given organism, for each antibiotic, they will tell you at what MIC cutoffs it will be considered susceptible, intermediate, resistant, and for some of these there will be a susceptible dose dependent, meaning that it would be susceptible as long as you give a certain amount of antibiotic. So if you click the link, you will go to CLSI's website where they will host the M100 document. The M100 document is the one that has interpretive criteria for all antibiotics. So it doesn't have antifungals or antivirals. It's specifically, gram positive and gram negative organisms. And then this is available for free. So you can just click to enter as a guest. And then you just make sure you click on M100 document, and this gets updated annually. So, for example, next year you will see the 2023 edition. So, keep that in mind. And then, once you go here, you can use the table of contents, and there is a table for each organism. So if you scroll down, you will see that starting with table 2A. So this one 2A is for Enterobacterialis, and then the next table is for Pseudomonas. The next one is for Acinetobacter. Next one is so on and so forth. So if you are looking for breakpoints for specific organism, we're gonna use Enterobacterialis for this example. So if you click Enterobacterialis, it will take you to the page for Enterobacterialis, and this document is intended for microbiology lab staff. So, a lot of this you can ignore. The part that you need when you look at the breakpoints is the table. So you will see that it has columns for susceptible, dose dependent, intermediate, and resistant. And there are two sets of them. So one of them is based on MIC. So if you are using an automated machine that gives you MIC, or if you're using e-test, this is the part you will use. And if you're using this diffusion where the diameter of zone of inhibition is important, they will tell you, how big does the zone need to be. So in this example, let's say if you have E. coli as the organism and you're testing against ampicillin in this diffusion, they're telling you that if you measure the diameter and if at least 17 millimeter, it will be susceptible. Now, if it's between 14 and 16 millimeters, it will be intermediate. And if the zone is smaller than 13 or less, it will be resistant, including, if the zone is 0, which means that it just grew through the disc. Now, you guys don't need to memorize any of these numbers. I'm just trying to show you how to use, how to navigate and use this document. Now, with MIC, so again, for susceptible, it will say MIC of 8 or less is susceptible. So in other words, if you test it and MIC comes back and it says MIC is 4, you look at here and say, oh, good, it's 8 or less. So, for that patient, it would be susceptible. But if you had, another test result come back and said the MIC is 16, you look here and say, oh, it's 16. So it's not susceptible and it's not resistant and it's intermediate. And what intermediate means is that if you're using the usual approved doses of ampicillin, it will likely not work. But if you were to use higher doses, it will probably work. And if it's resistant, doesn't matter. If you use the maximum dose that's safe in patients, it's just not going to work. So you do not want to use ampicillin if it's resistant. And so if the MIC comes back and it's 32, it's resistant. If it's 64, it's resistant. Now, with intermediate, also in general, if something is intermediate, we try to avoid it if we have other options. So occasionally, you may not have other options available. So in situations like that, we will have no choice but to use it if it's intermediate. But if it's resistant, under no circumstances will we be using that antibiotic. In this case, susceptible dose dependent doesn't exist. So susceptible dose dependent only exists for certain antibiotics. So for example, a good example is cefepime. So if you go down to cefepime, which is cephalosporin, you will see that under the column for susceptible dose dependent, they have listed 4 to 8. So this means that if you have, for example, Klebsiella pneumoniae, which is a member of Enterobacterales, and you get an MIC for cefepime back and it's 2, you're going to say, okay, good, 2 is susceptible. Now, if it comes back and it's 8, then you're going to look here and say, oh, it's 8. It's not susceptible, but it's susceptible dose dependent. And then you can look at the notes here. So what does that mean, dose dependent? And then they will tell you that essentially, if it's susceptible, it's based on if you're using a dose of 1 gram every 12 hours. But if it's 4 or 8, you need a higher dose of higher than 1 gram every 12 hours. And they guide you to Appendix E, where they have a specific recommendation. And essentially, you will see in that part that if it's MIC of 4, you need to have 1 gram Q8 or 2 gram Q12. And if it's MIC of 8, you need to use the maximum dose, which is 2 gram Q8. Maximum, as far as FDA approved maximum dose. And of course, if it's 16, it will be resistant. And because there is a susceptible dose dependent, then there is no intermediate. So they have eliminated the intermediate for this antibiotic. So that's how you navigate the CLSI document. Here's another example. So let's say we have identified E. coli, and then we did broad microdilution to see the MIC. So, looking at this, you can see that this test tube, this is cloudy, and these 3 are clear. So which means that organism E. coli was growing in these 2, but not here, here, or here. So the minimum concentration needed to kill E. coli in this example was 8. So MIC is 8. Now, just knowing the MIC alone doesn't tell you anything of what you can do. And I should say this is ciprofloxacin in these test tubes. So just knowing MIC is 8 doesn't mean if we can use ciprofloxacin or not. So what we need to do is to interpret this MIC. So CLSI document, I put a screenshot of the table here. You can see that for MIC, they say to be susceptible, it has to be less than or equal to 0.25. And then anything greater than or equal to 1 is resistant. In this case is 8, so it's definitely resistant. So this E. coli in this sample is resistant to ciprofloxacin. Even though, if you give high enough of ciprofloxacin, it's going to kill it, right? But it's considered resistant because we cannot given the safe doses of ciprofloxacin, we will not be able to achieve these concentrations in the human body. So we will consider resistant and not use ciprofloxacin for a patient who has this isolate. So that was phenotypic testing. Now let's take a look at genotyping testing, which is a much faster process. So these are commonly referred to as rapid diagnostic tests, also called molecular tests because they detect genes in these organisms. So there are different technologies available. One of the most common ones is a PCR, or polymerase chain reaction. A multiplex PCR, an example of it is BioFire BCID2 panel. BCID is the actual test. It stands for blood culture identification. This is the second revision of this test, or version 2, if you will. And the significance of this is that it can detect a series of organisms that's listed here. So a number of clinically important organisms that cause most common infections, including gram-positive and gram-negative bacteria, as well as certain species of fungi such as Candida and Cryptococcus species. Now, if it doesn't detect anything, it could be that there is an infection due to organisms that are not listed here, so it will not detect it. But also it is possible to have a false negative. But that is extremely rare because these tests as PCR have extremely high sensitivity. So the probability of a false negative is pretty much extremely rare, less than 1%. Now, these tests can also detect resistant genes. So there are a number of them listed here, which we will discuss in another time. Now, you don't necessarily need to memorize the list of these organisms and these genes, but what you do need to know is that this test is capable of detecting some of the most common genes for resistance. And this test is pretty fast, so you can have the results within an hour. Now, the caveat is that it will take some time for organisms to grow in the sample, and once you have a colony formation, then you can put the sample in this test. So it takes some time for those colonies to form. So it's not quite as fast as 1 hour when somebody presents to the emergency department. Another example of a PCR is a Verogen test, and it comes in two different panels. One is a gram-positive blood culture and one for a gram-negative. So you can see the organisms again are listed here. It works in a similar way, so it will detect genes from these organisms. So if they are detected, they are suggestive of presence of the organisms in the sample. And there are certain resistant genes that this test can detect, including some of the gram-positives and some of the gram-negatives. Now, this is still pretty fast, so it's a rapid diagnostic test, but a little longer. So it takes about 2.5 hours once you put your sample in this machine for the results to be reported. And there is also the NAPLEX BCID test that works in a similar way with similar organisms and resistant genes detected. Now, beyond PCR testing, we have other technologies. So we have MALDI-TOF. MALDI-TOF essentially can detect any bacterial and fungal organism. So it's a very powerful tool and it's pretty quick, so about 30 minutes. However, it cannot detect resistance, and there's a question mark here because it is an area of active research. So, people are researching ways to decode resistance, but clinically at the moment, this is essentially used purely to identify organisms, not necessarily detect resistance. Beyond that, we have FISH, and you can see what these abbreviations stand for, but these are different technologies. So FISH, we have Accelerate Phenotest BC that can detect a number of similar pattern of organisms, so number of gram-positive and gram-negative organisms as well as candida species. Now this one is a bit unique because it can also report MIC, so it's not necessarily detecting a gene. So it's not the when it comes to resistance, it's not the genotypic test. It is a phenotypic test because it can report MIC for select number of antimicrobials. So it takes about 2 hours to detect the organisms, and it takes about 7 hours for these MIC results to be reported for accelerated phenotest. And last but not least, we have NMR and PCR. So we have a test called T2 bacteria, and this can detect Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumoniae, Pseudomonas aeruginosa, and E. coli. And at the moment, it cannot detect resistance. And this one is very fast. It takes 3 to 5 hours, but it's the time starts directly from the whole blood. So it's significantly faster than the rest of the rapid diagnostics. So if you consider when a patient comes in and we take a sample, for majority of rapid diagnostic tests, it takes some time, typically at least half a day, for this incubation to result in the number of colonies, and then those colonies go into rapid diagnostic tests. T2 bacteria is unique where you can actually take your sample directly from the blood, from the whole blood that was received from the patient without the need for incubation. This goes directly into the T2 bacteria, which significantly improves the time to identification of these organisms. However, the caveat is that, or I should say the downside is that there's only a limited number of organisms that this can detect. But as time goes on, I anticipate that this test will in time be able to detect more organisms as they research and develop this test. Given the results of a specimen stain, we listed the most likely organisms present in the specimen, and we described the basic process of microbiology testing for identification and susceptibility. Now, let's identify the normal human flora and the role in infectious diseases. Let's take a look at the terminology of the human microbiome. The term microbiota in general refers to the collection of all living organisms present in a specific ecosystem or environment. In human microbiota, we're specifically referring to all living organisms, including bacteria, fungi, phages, archaea, and protists that live in the body. And we are specifically talking about these organisms that are not necessarily causing an infection, so these are a normal part of the human health. The term microbiota specifically refers to the fungal component of microbiota. And when we say all living organisms, it essentially does not include viruses because viruses are not considered living organisms. The term microbiome specifically refers to the combination of the microbiota together with the elements that are crucial to their function, including the collective genomes of the microorganisms present. So if you can think of the human genome, which is essentially the genes from the human DNA, so the human genome is around 23,000 genes. When we compare that to the microbiome, the genes present in microbiome are estimated to be somewhere between 3 to 10 million genes up to over 200 million genes. And there's a large variation in this because of inter-individual variation in the microbiota. But that tells you the essentially the scope of how many genes the microbiome contributes to the human health. And because living organisms do not include viruses, there is also the term virome, which comprises bacteriophages or phages that infect bacteria, viruses that infect other cellular microorganisms such as archaea, viruses that infect human cells, and viruses present as transient in food. Let's take a look at the development of human microbiota. So we start at the beginning of life. Although there is debate regarding the existence of the placental microbiome, the current consensus is that the healthy placenta and fetus are devoid of microbiota because of the immune system's effective sterilization, thereby preventing colonization by microbes. In fact, the presence of bacteria in the amniotic fluid contributes to premature birth. Now, upon birth, this is where the human microbiome starts to develop. The first 1,000 days are crucial in developing a healthy microbiome. So that's essentially about the first 3 years of life when the microbiome gets set for life. And of course, throughout life, there is variation to microbiome. It is essentially affected by lifestyle, diet, and other things such as drugs. At birth, through vaginal delivery, the baby will be exposed to vaginal microbiota, hopefully a healthy vaginal microbiota, which includes Lactobacillus species. And this is the first opportunity for the microbiome to differ in persons when you consider babies that are born through a cesarean section. They will essentially be exposed to bacteria from the skin. And this is skin microbiota that are representation of the bacteria in the operating room when where the C-section is done. Now, upon birth, whether through vaginal delivery or C-section, other things that affect the microbiome early in life includes whether the baby is breastfed or formula fed. Human milk has probiotics naturally, so it has bifidobacteria and lactobacillus, whereas formula, it depends on which formula people use. They essentially have to mimic a normal microbiota. Essentially, the consensus right now is that breastfeeding is much healthier for developing a healthy microbiome, whereas formula feeding deviates from a natural microbiome development. Now, when it comes to infectious diseases, it is helpful to know which sites in the body are sterile. So essentially, in general, it's considered that all internal organs are sterile. So organisms are not supposed to be there. So for example, blood is considered sterile. So if you have a healthy person, if you take their blood sample and culture it, nothing should grow. The same is true with central nervous system, cerebral spinal fluid or CSF, liver and spleen. In fact, the liver and the spleen have a role in clearing the blood and catching if organisms are, if bacteria make their way into the blood, the liver and the spleen have a role in clearing them. The kidneys are supposed to be sterile, and the lower bronchi and alveolar are considered sterile. And there's a question mark here. It's a matter of how deep you go into the lungs, because there is a lung microbiome. So it's a matter of how deep you go into the lung. And bladder, for some individuals may have bacteria present in their bladder without having an infection. But early in life, especially younger men, essentially have a sterile bladder. But as people get older, especially older men are likely to start to have organisms in their urine. In women throughout life, although many women have a sterile urine, it is not uncommon to have women have organisms as part of their urine microbiome. Now let's consider other sites where it is usual to have bacteria present. So the skin is notorious for having gram-positive organisms, so Staphylococcus epidermidis. In fact, the term epidermidis means above the skin. Other organisms, Streptococcus pyogenes, Staphylococcus aureus, Corynebacterium, Cutibacterium, and there are many other organisms that are not listed. I'm just showing you the most common ones where it is helpful to know, so that when you encounter these in clinical settings, you can make decisions. For example, while these organisms are present as part of a healthy skin flora, if there is a cut in the skin, for example, they can turn into an infection. So you can, anticipate which organisms might be causing an infection. In the vagina, Lactobacillus is a healthy microbiome. Sometimes you may find group B streptococci in vagina, which is something that's screened for in pregnancy, because it can lead to complications during pregnancy at birth. Other organisms include Listeria and E. coli. In the mouth, we do have an oral microbiome, so typically Streptococci species and some of the anaerobes, including Peptostreptococcus and Fusobacterium. And this slide is just an FYI, just to show you the essentially the depth of the oral microbiome. So inside the mouth, even at different regions of the mouth, you will anticipate different organisms present. And of course, some of these can lead to health issues, especially when you consider gingivitis and other dental issues that you can discuss with your dentist. And then the microbiome continues throughout the GI system. So the esophagus, for example, has a microbiome. So this is where you will see a lot of the organisms. And by the way, bacteria that belong to the flora in the oral microbiome and esophagus do feed throughout the GI tract. Now, before we discuss the GI tract further, let's talk about the respiratory tract. So as I mentioned, the lung does have a microbiome. So when I say respiratory tract, it starts, pretty much from the nares, so nasopharyngeal area, and goes all the way through bronchi and into the lungs. But the further you go into the lungs, the less likely to have organisms present. So the respiratory pathogens or bacteria, I should say, include Staphylococcus aureus that may be present in the nose, for example, Streptococcus pneumoniae and other streptococci. Some of the gram-negatives include Haemophilus influenzae, Moraxella catarrhalis, Neisseria meningitidis, Peptostreptococcus, and Fusobacterium. And again, the presence of these organisms doesn't necessarily mean an infection. They are part of the lung microbiome, but when you do develop a respiratory infection, these are the organisms that might be causing them. So here's a look at the respiratory tract. So you can see that at the nasal. Again, this picture is an FYI, but you can see that there are major changes throughout the respiratory tract. Of note is that the pH actually increases as you go deeper, which means that, in general, the acidic environment helps prevent the presence of organisms, but as the acidic environment reduces, it creates an opportunity to bacteria to grow. However, there are other mechanisms to prevent bacteria to go deep into the lungs. So there are, for example, coughing and other ciliary movement that prevent the movement of bacteria into the lungs. So you can see that when you look at the density of microbiota, essentially, the numbers increase somewhat as the pH increases, so meaning it becomes a more basic environment as opposed to an acidic environment, but then the numbers drop just because there are mechanisms to prevent bacteria to flow deep into the lungs. Now let's go and talk about the rest of the GI tract. So we talked about oral microbiome and the esophagus. Then once you get to the stomach, it's highly acidic, so a lot of bacteria and other organisms die once they make it to the stomach. However, some organisms can make it through, and pretty much this is highly acidic environment, including the duodenum, jejunum, and the rest of the intestines are all acidic. It's just, the intestines are less acidic, whereas the stomach is extremely acidic. So the number of organisms increase as you go further down. One thing to consider is the lining of the GI tract. So you can see that there is a single layer of a cell that makes up the lining of the gut. And there is a layer of mucus on top of this as a protection. And, on top of the mucus is where your microbiome essentially exists. That's where fiber from the diet will come in and these bacteria will consume it. And occasionally they can, make it through the mucus if there is an interruption of the system. And another characteristic of this is that there are microbial communities. So these bacteria essentially live together as part of communities. So they are pretty resilient. So, as you can imagine, the bowel movements that occur essentially they stick around, and the next time a meal comes in, they are able to reproduce and digest food and essentially ferment the fiber that comes through the diet, and they continue to replicate. In fact, more than 50% of the weight of feces that come out of the rectum is bacteria, like pure bacterial mass. Now here's a look at as we progress from the stomach all the way through the intestines. You can see that bacterial load increases significantly. Another thing to consider is that oxygen levels actually decrease. So the further you go from the stomach, the more you are going to have anaerobic organisms, and of course the pH will increase. And again, I will say that although the pH increases significantly throughout, this is still an acidic environment. So there's still going to be pH less than 7. It's just that, in the stomach, the pH is around 2. So it's very acidic. And as you go further down, the numbers goes up, but still is pretty acidic. And of course, there is a layer of mucus on top of the GI lining. So let's take a look at the major organisms in the GI tract. So essentially Enterococcus faecalis, and you can tell from the name faecalis that's, if you can think of feces, Enterococcus faecalis is present in the GI tract. Other organisms include Lactobacillus species, Peptostreptococcus, Clostridium species, E. coli, Klebsiella, and a major one, which is an anaerobic organism, is the Bacteroides species. There is a number of Bacteroides species that are an important part of the GI tract. Now, of course, there are a lot more bacteria that I have not listed here. I have listed here the major ones that are helpful to know when it comes to clinical situation. Now, because there are so many organisms in the GI tract, it is helpful to organize them by phylum. And here I have listed the phylum in the order of decreasing abundance of phyla, not necessarily the species or genus, but by phylum. So Firmicutes or Firmicutes, which were actually renamed Bacillota in 2020, are by far the most abundant phyla in the GI tract, followed by Bacteroidetes and some of the other phylum. So most commonly you will see Firmicutes in the GI tract. Of note, there are no probiotics available that belong to Bacteroidetes. So essentially you cannot replace these in the GI tract. And what you can see in the genus, and this is not an all-inclusive list, but some of the more commonly studied species that are, or genuses that are listed here, what's in bold is available as probiotic product in the US. So for example, Bacillus subtilis, Hendrixia coagulans, which was previously called Bacillus coagulans, Lactobacillus, Streptococcus, Clostridium, Bifidobacterium, and more recently Akkermansia species are available as probiotics. Now, a couple of concepts to keep in mind is the concept, one is the concept of contaminant. So a contaminant is an organism present in a culture specimen that is deemed to not be the primary cause of infection. In other words, if you were suspecting an infection and you took a specimen from the site of infection, but it got, because it's easy to get that contaminated, meaning bacteria from other places, perhaps the person handling the sample or from other environments make it to the sample, that's essentially the contaminants. And there are techniques that people can use to minimize the risk of contamination of the sample. The second concept is a colonizer. So a colonizer is an organism that is present at the body site but does not normally cause harm or pathogenic effects. In other words, if you were suspecting an infection and you found an organism at the site of infection, that may or may not have caused the infection. So if you didn't think, just because you found this organism, it could have been an innocent bystander, which we call a colonizer. And lastly, it is important to keep in mind that a healthy microbiome is essential for health, which has led people to research the human microbiome significantly in the past few years. So for example, you can think of pretty much different sites in the body, and you can have a balanced microbiome, and then you can have an unbalanced where the microbiome is interrupted and other organisms have been growing in that area. In fact, the most studied part of the microbiome is perhaps the GI tract. So you can see from the esophagus to duodenum, jejunum, ileum, and the colon. There are a number of healthy organisms that we anticipate a healthy person to have. And when we study certain conditions, for example, the most studied include obesity, diabetes, and gut inflammation. These are notoriously associated with gut dysbiosis, meaning that the healthy microbiome has been interrupted and other essentially phyla have become dominant. Which brings us to a few concepts about nurturing the microbiota. So there's a concept of prebiotic. So prebiotics essentially refers to non-viable substrates that are selectively used by host microorganisms and confer a health benefit to the host. This is essentially fermented fiber. So this is the food for the microbiome. That's very important to nurture the microbiome. The next concept is probiotics. So prebiotic is the food for probiotics. So probiotics, the definition is live microorganisms which, when administered in adequate amounts, confer a health benefit to the host. And lastly, there is a concept of postbiotics. So if we think there is a health benefit from probiotics, this is essentially through many mechanisms, some of which is thought to be the byproducts that are produced by probiotics. So when probiotics, essentially when they ferment these probiotics, they lead to certain soluble factors that are secreted by these organisms. And they essentially lead to signaling in the human body that will have the actual health benefits in the body. An example of postbiotics include short-chain fatty acids that you may hear about in the news, for example. Now, because of the effects of microbiome on health, there is significant interest in restoring the gut microbiome. So we talked about early in life, for example, through vaginal delivery. That is when the baby gets exposed to a healthy microbiome through the, essentially the vaginal microbiome, and C-section will prevent that. So one idea is the idea of vaginal seeding. So this is specifically for someone who is about to undergo C-section because they will miss the opportunity of getting exposed to vaginal microbiome. The idea is that an hour before the C-section, a vaginal gauze is collected before the procedure. So this is essentially collecting all the vaginal microbiome. And then the C-section occurs, and once the baby is born, the neonate is swabbed within 2 minutes of birth. So essentially they swab the face and the back of the baby. Now, there is limited studies on this, so I'm not saying that this is something that's routinely done, but this is something that's emerging. There is, for example, one RCT of infants born by cesarean section that showed that vaginal seeding improved infant neurodevelopment compared with placebo, and more importantly, it showed that vaginal seeding was safe, and the reference is down here. And more human studies are needed for this, but this is a promising strategy. Another thing that people are looking into is the fecal matter transplant. So essentially for people who have dysbiosis, if you get a fecal sample from a healthy person and you process it to get all the healthy microorganism, and then you administer it through colonoscopy, for example, to replenish the organisms in the gut. And this has mostly been studied in treatment of Clostridioides difficile colitis infections, but there is also emerging evidence in other conditions through these mechanisms. But certainly more studies are needed. And lastly, of course, what most people are familiar with is the idea of giving probiotics, for example, yogurt, or perhaps probiotics as a pharmaceutical administration. And when you take these along with prebiotics, and again, prebiotics are the food for probiotics, together in the same capsule, these are referred to as symbiotics. And the idea is that, with regular administration, this can essentially restore the gut microbiome. And certainly in this area, there is a lot of studies done, and more studies are needed. And lastly, these are very difficult to study when it comes to any strategy for restoring a healthy gut microbiome, because there is significant individual differences in the microbiota. So if you have two healthy individuals, you're going to have significant difference in the oral microbiome, skin microbiome, vaginal microbiome, GI microbiome. So it's really difficult to define a specific composition of microbiome that's considered healthy, because you're going to have multiple definitions, and what's the right microbiome for an individual, it's a question that's still open for research. We looked at the results of a specimen stain to list the most likely organisms present in the specimen. We described the basic process of microbiology testing for identification and susceptibility, and we identified the normal human flora and the role in infectious diseases. Now, let's explain the antimicrobial stewardship process for initiating, monitoring, and streamlining effective and safe antimicrobial therapy. The first thing to do in a systematic approach to infectious diseases is to start with the question, what are we treating? And there are 4 questions to ask. First, did you determine the infection site or type using subjective and objective patient information? That includes signs and symptoms that are specific to an infection type, or it could be general manifestations of infections. Second, did you assess severity using SIRS or an infection-specific tool to determine where the patient should receive care? As we learn about different infections throughout this course, we will talk about infection-specific tools that are relevant. Determining the severity of disease can help triage the patient to the appropriate setting in order to receive appropriate care. And in general, we can think of the settings as outpatient or inpatient. So if someone who is less severely ill and is ambulatory, meaning that the patient is able to walk, so the infection is not severe enough to prevent them from walking, this patient can make appointments at the clinic, make appointment with the primary care physicians, or in an ambulatory care clinic with a pharmacist in order to receive care. Now, slightly more urgent would be if the patient is still ambulatory but needs urgent treatment. So that for that reason, the patient can go to an urgent care. And then we have emergency departments. And this is kind of an overlap between outpatient and inpatient, because when people go to the emergency department, they do not necessarily get admitted to the hospital. So a lot of patients who go to the emergency department may actually get treatment and get discharged home. So they may go home with a prescription. So they will go to the pharmacy, either the outpatient pharmacy at the hospital or perhaps to the community pharmacy to receive medication, but may not necessarily require admission to the hospital. And on the other hand, some patients may be sick enough at the emergency department that would require admission to the hospital. So once that's determined that a patient needs to be admitted to the hospital, they will be sent to the general ward on the floors of the hospital. And that is where patients will receive care inside the hospital. And in severe cases, in critically ill patients, they may receive more specialized care inside the intensive care unit. So patients may actually need to go to the ICU. So that would be the most severe disease. Now, the third thing to consider is, did we obtain cultures from the infection site before starting antimicrobial agents and remove the infection source? So source control is important, because if the source of an infection is still there, doesn't matter how much antimicrobial agents you give to the patient, the infection continues to come back. So source control is important. And the reason you want to get cultures before giving antibiotics, because even a single dose of antimicrobial can pretty much eliminate organisms from the specimen, so it would be difficult for us to grow it in the culture. Even though a single dose may not necessarily treat the infection, but it would reduce the inoculum in the specimen enough that it will be difficult to have a good yield out of the specimen. And fourth, did you list the causative pathogens from most to least likely? And this is, initially, before we actually identify what's growing in the specimen, it's a guessing game. So we have to, based on the signs and symptoms and the infection, we have to guess what's the most likely pathogen so that we can target those pathogens empirically before we actually find out what's causing the infection. Now, the second thing to consider is how can we ensure that the patient receives the most effective therapy? So let's focus on efficacy before we move on to safety. Of course, the first thing we want to do when possible is to make sure that we use reliable resources to select non-pharmacologic therapy. Then we consider reliable resources to select the antimicrobial regimen of choice. So in general, for most infections, we have first-line therapy and we have alternative therapy. So when the patient can get first therapy, that would be the best approach. And occasionally, the patient may not be able to get first-line therapy for various reasons that we will discuss, and that's when we can go to alternative therapy. And the next thing to consider, if more than one option is listed, did you use an antibiogram or another reliable source to select a regimen with activity against a high percent of likely causative pathogens listed in checklist item number 4. And here's what an antibiogram looks like. So here's an example of the antibiogram from Loma Linda University Medical Center. So here you can see that each row is a different organism. So for example, the first line of organisms is Acinetobacter baumannii. And then this, in the second column, they're showing you the number of isolates. So isolate means, pretty much how many times this organism was growing inside the microbiology laboratory. So for example, if we had, and these are unique to a patient. So in other words, if we sent 2 blood samples from the same patient and E. coli grew in both, that counts as one isolate. Okay, so if you had multiple patients, so it essentially tells you over the time period that this antibiogram is reporting. During that time period, this organism was isolated in the lab 53 times. And then they're reporting you their susceptibility, the percentage susceptible to each antibiotic. So if there is a dash, that means they just did not test against that antibiotic because they're not routinely tested. So it's reported for things that are routinely tested. So for example, ceftriaxone. So when they checked susceptibility of Acinetobacter to ceftriaxone, it was susceptible 17% of the time. So that's pretty bad. Only 17% of the isolates were susceptible to ceftriaxone, whereas when you compare that to meropenem, that's slightly better. So that's 30% of the time. And if you look across, these numbers look pretty bad because this organism is highly resistant to most antimicrobial agents. So that's why these numbers look pretty bad. Now, if you look at another organism such as Citrobacter frundii, there were 31 isolates during this time period at the micro lab. 35% of these were susceptible to ampicillin. And let's say 100% of them were susceptible to imipenem and meropenem, and 81% were susceptible to trimsulfa. Okay, so you can do the math. So this is reporting susceptibility. So let's say if 97% of Citrobacter frundii was susceptible to gentamicin, for example, that means the remaining 3% was not susceptible. So if you want to identify resistance, you basically subtract this from 100. So for amikacin, for example, the resistance rate was 0% because 100% were susceptible to amikacin. So that's how it's reported. And for some organisms, there also report a subclass of those. So for example, E. coli, we'll talk about what ESBL means on another lecture, but Some E. coli produce something called ESBL, so they're showing you that for those isolates specifically, what the susceptibility look like. And another good example is Staphylococcus aureus. In general, we like to classify Staph aureus either as MSSA or MRSA, and essentially, in the line with Staph aureus is showing you all of the isolates of Staphylococcus aureus, regardless of whether it's MSSA or MRSA. And then the next line includes MSSA only, and the next one is MRSA only, and then they show you susceptibility. So that's how an antibiogram looks like. And in general, for most times, you want numbers that are at least 80% susceptible and higher. So that would be pretty good. So these numbers under 80% are pretty bad. So if you have options, you want 80% or higher. In the ICU, when patients are critically ill, you really want 90% or higher for most infections. So that's something to keep in mind. And now you have to take that with a grain of salt. So it doesn't mean that you should only use the highest numbers. We'll talk about how to choose, because this is only one factor when we select antimicrobial agents. So once you have 80% or higher, that's good enough for most infections. You don't necessarily want to start with 100%, and we'll talk about that more on a future lecture. Now, the next thing to consider is, did you consider the active antimicrobial agents with the narrowest spectrum the drug of choice? So in general, we want to avoid a broad spectrum and focus on narrowest spectrum possible, and we'll talk about that on a later lecture. And penetration is also important. So depending on the type of infection you're treating, you want to make sure that the antimicrobial agent actually penetrates to the site. And here's what it means. So essentially, in general, we either take antimicrobials orally, so it goes in through the mouth and then it's absorbed and goes into circulation, or it's directly injected into the blood. And there are other routes, but in general, we'll focus on intravenous and oral routes in this course. And if your infection is, for example, meningitis, you really want to make sure that antimicrobial agents you use actually penetrates into the site of infection. So it's important to know, what percentage of the drug from the blood actually goes through the cerebrospinal fluid, or CSF. So that would be significant for meningitis. If you're treating a urinary tract infection like cystitis, you want to make sure that the drug actually goes to the urine. So for example, if a drug is not renally cleared, it's not going to go to the urine. So even though you get a large concentration of the drug in the blood, it's not going to go to the urine. So you want to make sure you choose something that goes into the urine. And so on and so forth. So for skin and soft tissue infection, you want to make sure it penetrates the skin. For bone infections, which we call osteomyelitis, you want to make sure you get bone penetration. For peritonitis, which is in the peritoneum or peritoneal space, you want to make sure that the drug penetrates that area. Occasionally, if the infection is inside the intestines, for example, Clostridioides difficile colitis, you actually want to make sure that the drug stays in the stomach and is not absorbed into the blood. Or if you're injecting into the blood, you want to make sure that it can actually go into the intestine. Otherwise, it's not going to get to the site of infection. And for pneumonia, which is infection of the lungs, you want to make sure there is penetration into the lungs and epithelial lining fluids. So penetration is important. And for severely ill patients, you want to make sure that you consider using IV antimicrobials empirically, when appropriate. So in general, people who are severely ill, they may not have, for example, if you give them orally, they may not absorb it quickly. Or patients are sick, so they may be vomiting, so you don't want them to vomit the antibiotics out. So IV in general is initially appropriate, and of course within reason. So again, if you're treating C. diff colitis, you want to make sure that an oral route might be a better choice because the infection is inside the intestine. So you have to use these things cautiously. But in general, for most infections, IV is initially appropriate for severely ill patients. And the third thing we want to consider is we want to make sure that it's what we're giving the patient is safe. So for patients with drug allergies, you want to avoid selecting antimicrobial agents that may cause allergic reactions. If a patient is pregnant or of childbearing age, you want to avoid teratogenic agents. You want to evaluate if a patient is at high risk for adverse effects, or if there is contraindications, you want to avoid those in the patient. You always want to check for drug-drug interactions if the patient is taking other medications or over-the-counter agents, including herbals, supplements, etc. For immunocompromised and those with meningitis or endocarditis infections, we want to consider in general bactericidal antimicrobials. Now this is a bit controversial because the evidence for this is not clear, so it's not studied well. But in theory, we think that bactericidal may benefit patients who are immunocompromised or have meningitis or endocarditis. And here's what that means. So essentially, the definition of bacteriostatic means that the agent prevents the growth of bacteria, whereas bactericidal means that it actually kills bacteria. So let's look at this graph, the graph in the middle on bacteriostatic. So here on the x-axis, we're looking at time, so 2 hours, 4 hours, 6 hours, and 8 hours. And on the y-axis, we are looking at cell density measured in colony-forming units, or CFU. So the first line you see is essentially the control, meaning that we have a certain bacteria, and assuming that the conditions are correct for growth, meaning there is food for the bacteria to consume and the temperature and all the conditions of the environment are correct for growth, if you leave it alone, it will grow over time, right? So 2 hours later, 4 hours later, the number of colonies will increase. And if you give antibiotics, it will essentially prevent the growth. So what bacteriostatic means, and some examples include tetracycline, erythromycin, and linezolid. If you give any of these bacteriostatic agents, it will essentially prevent the growth, okay? So it's essentially preventing the growth. Now on the right-hand side, the same thing is done with bactericidal agents. So you can see again the control line. So if you leave it alone, the colony-forming units will increase over time. Now these are bactericidal, then they actually mean that they will drop the number of colonies. So it's not just a flat line. They actually decrease the number of colony-forming units over time, and some of them, more rapidly than others. So, for example, aminoglycosides such as gentamicin are famous for rapidly dropping the number of colony-forming units. So it actually kills pretty fast, and some of them kill slower. And these are all experimental in vitro. So this is not necessarily inside a patient's body, but inside a test tube where these experiments have been conducted. So the theory is that if somebody is immunocompromised and they don't have the benefit of immune system, this might be dangerous to just prevent the growth because there is no immune system to actually kill it. So you want to rely on bactericidal to kill as many of these before the bacteria kill the patient. Now, this has come under scrutiny because a systematic review of many studies actually found that for the large portion, there is no clinical difference between bacteriostatic and bactericidal agents. So in general, it doesn't matter. However, the studies, there are not good studies looking at this specifically in immunocompromised patients like transplant patients or those with endocarditis and meningitis. So some of these are based on case reports that have shown there may be benefits to bactericidal. So it's a bit controversial. In general, doesn't matter if it's bactericidal or bacteriostatic unless you're dealing with immunocompromised meningitis or endocarditis. And the next thing to consider is, if you have multiple options, you want to choose the most affordable option for the patient. Now, the fourth thing to consider is how can we ensure the patient receives the right dose? So you want to optimize the dose of antimicrobial, and this is important for us as pharmacists. So in general, you may consider a loading dose, if it applies to the antimicrobial agent, and you want to make sure that you use appropriate body weight. So sometimes some agents are dosed based on ideal body weight, sometimes adjusted body weight, and sometimes total body weight. So you want to make sure you are using the correct weight when calculating the dose. And sometimes you need dose adjustment. So depending on renal function and liver function, you may need to adjust the dose based on that. And in severely ill patients, or any time that you have MIC data available, you want to optimize PK/PD. And I'll talk about what that means in a minute. For outpatients, you want to make sure you increase adherence. So in general, it's hard to improve adherence if you give the drug more than twice a day. Ideally, once a day is best for adherence, but twice a day sometimes is difficult to avoid. But anytime you have the option between twice a day and 3 times a day, or worse, 4 times a day, you really want to do twice daily to improve adherence. And of course, always think about duration of therapy. And in general, shorter the duration of therapy, the better, because of adverse effects and unintended consequences of antimicrobial agents. So you want to choose the shortest duration of therapy that's proven to be effective. Now here's PK/PD. So pharmacokinetics in general means what the body does to the drug. So in general, you can think of, once you start giving the drug, the concentration keeps going up. And then once you stop giving the drug, and whether it was oral, so this was oral absorption, or if you were giving it intravenously, this is when you stop infusion. Then you have a drop in the concentration, so the body starts eliminating from the body. So that's pharmacokinetics. And pharmacodynamics is about what the drug does to the body. So essentially, you measure the effect. So initially, there is no effect. As the drug enters the body, you start to see the effect. And at some point, there is like a ceiling effect. There's only so much effect you can give, right? That's in general. When it comes to antimicrobial agents for infectious diseases, we like to combine pharmacokinetics and pharmacodynamics because they can only make sense together. So the way we think of pharmacodynamics is that we need to consider MIC, and MIC is the minimum inhibitory concentration of the drug. And there are some PK/PD parameters, such as the ratio of maximum concentration to MIC, or the ratio of area under the concentration curve to MIC, or the time that the concentration is above the MIC. And we'll talk about those on a future lecture of when to use each of those and what they mean. But these are essentially the PK/PD parameters we use. And the reason I am emphasizing this is that there is a lot of variation or variability between patients. So there is inter-individual variability. So you can think of age, there is a difference in pharmacokinetics between a young adult and an older adult. Sometimes race and ethnicity can make a difference. Obesity can affect pharmacokinetics, comorbidities, medications, and there are also intra-individual variability. So depending on what's going on, sometimes there is altered fluid balance. If you're giving a lot of fluids to the patient, that can change pharmacokinetics. If there is renal or hepatic dysfunction, or if there is organ support. I'll talk about some of these in a minute. And then pharmacodynamic factors are things such as host immune response. So sometimes patients might be immunocompromised. Inoculum size. So sometimes, an infection can have a lot of bacteria at the site of infection. That's referred to as the inoculum size. Or sometimes there may be just a few. So the higher the inoculum size, the more difficult it is to eradicate the bacteria from the site of infection. We talked about tissue penetration at the site of infection. There are things like biofilm that we'll talk about on another lecture. And there are other things that affect pharmacodynamic pharmacodynamics. Now, when it comes to critically ill patients specifically, there are important things to consider. So, for example, there are 3 things I have listed on the left-hand side that can lead to reduced plasma concentrations. So, for example, hyperdynamic environment in the patient. So, whether naturally if the body is responding to let's say a drop in blood pressure due to the infection, or whether we are actually causing this by giving pharmacologic agents such as vasopressors. If the cardiac output is increased, because we want to bring the blood pressure back to normal, so the patient doesn't go into shock, or the patient is already in shock and we're trying to bring them out of shock, that can increase perfusion to other organs such as the kidneys and can lead to increased elimination of the drug, so your plasma concentrations may be lower. So this is something to consider, which means that in the ICU you may need higher doses of the drugs. Another thing is alter fluid balance. So again, if you're giving a lot of fluids to the patients, it keeps diluting the concentration of our antimicrobial agents, so we may need to increase the dose. Sometimes there is third spacing, so if the fluids keep going into, let's say, peritoneal space or in other third spaces, the drugs can get diluted, and so plasma concentration will be lower. The same with protein binding. So if you have drugs, for example, ceftriaxone is highly protein bound. So if there is altered protein binding, so for example, if the patient's albumin is less than 2.5, then there isn't enough albumin around to hold on to ceftriaxone, which means that unbound ceftriaxone will be eliminated from the body, so you'll have reduced plasma concentration, which means that you may need to increase the dose. And there's also the phenomenon of augmented renal clearance. This is specifically defined as creatinine clearance greater than 130. So in other words, normally pharmacies dose adjust based on renal dysfunction, right? So if the creatinine clearance, let's say, is less than 60 or less than 30, depending on the agent, we like to reduce the dose. This is the opposite. So augmented renal clearance essentially means the kidneys are working too well, so it's clearing the drug too much, so you actually need to dose adjust in the other direction. So you need to increase the dose because of reduced plasma concentration. And things that can lead to augmented renal clearance include things like trauma, sepsis, burns, hematologic malignancy, or pancreatitis. These are some of the risk factors, and this is more common inside the ICU. And of course, it's possible that the patient may have no organ dysfunction and be critically ill, which means that your plasma concentration are actually normal. And then on the other end of the spectrum, we have if you have increased plasma concentration, so either because of renal or hepatic dysfunction, so the drug is not getting cleared. So your plasma concentration go higher, so you need to dose adjust and reduce the dose. And sometimes there is organ support. So if there is renal replacement therapy or ECMO, you may have increased or decreased plasma concentration. For example, if someone is on renal replacement therapy, essentially the kidneys are not working, so you may have increased plasma concentration. And then also depends on the settings of the dialysis and whether it's how well it's clearing the drug, so you may have increased or decreased plasma concentration. And then things like ECMO can increase volume of distribution, and sometimes the drugs can get attached to the equipment, so it can lead to reduced plasma concentration. And here's what ECMO looks like. So ECMO is essentially kind of what dialysis is to the kidneys, ECMO is to the lungs. So dialysis, essentially the kidneys cannot work, so dialysis takes over the kidneys and it adjusts toxin, it removes toxins from the blood, and it balances fluids and electrolytes, among other things. What ECMO does is if the lungs don't work and cannot oxygenate the blood, so essentially the blood will go into this machine. The machine will exchange gas. It will exchange oxygen for CO2. So it puts oxygen into the blood and removes CO2 from the blood, and then this goes back through the pump into the body. So this is a big machine, and as you can imagine, the blood is going through this big machine, so volume of distribution changes, but ultimately drugs can also get stuck in this machine, so that will affect your drug levels or concentrations. And the best thing to do is to do therapeutic drug monitoring to actually when available, because we cannot do therapeutic drug monitoring for every drug. But when available, the best thing to do is to actually measure plasma concentration and see if it's decreased or increased, and make adjustments based on that. For example, a good example is vancomycin, where we can get plasma concentrations, and based on the level, we decide whether we should increase the dose or decrease the dose or leave it untouched. The last thing that we should consider is how can we ensure this works and does not happen again. So we do want to specify how and how often we'll monitor for efficacy and safety. If cultures and susceptibility results have returned, you do want to go back to number 8 and start from number 8 in order to optimize the dose and regimen. And did you recommend immunizations and other preventive measures? So that's important. And lastly, as pharmacists, you do want to provide counseling, not just about the antimicrobial agents, but also about the infection. So what to expect from the infection, how often, what to look for, and what to expect as far as resolution of signs and symptoms, and of course, what to expect of antimicrobial agents adverse effect profile, how to take it, with food, with water, without food, or and how long to take this. Now, something to consider in patients who are hospitalized is VTE prophylaxis, or venous thromboembolism, because they are bedbound and they have limited movement, and of course they have underlying increased inflammation, among other things. Now, not everybody who is hospitalized is at increased risk of VTE. In particular, patients who have heart failure, COPD, acute infection, atherosclerotic vascular disease, or malignancy, when hospitalized, they are at increased risk of VTE. So in this course, because we talk about acute infection, anytime someone is hospitalized because of their infection, you should consider if they qualify for VTE prophylaxis. Now, VTE risk is 8 times greater in hospitalized patients versus general population, and non-surgical patients account for up to 80% of all fatal thromboembolic events and up to 70% of symptomatic thromboembolic events. This can add up to 8 million hospitalized acute medically ill patients at VTE risk in the US, which about 200,000 VTE related events can occur. So when you look at this chart, you can see that VTE, about a good chunk of it, about 20%, is due to hospitalized patients due to medical reasons. And medical, we're referring to things like heart failure, COPD, acute infection, vascular disease, and malignancy. The 2012 CHEST guideline advocated using a Padua score to identify high-risk versus low-risk patients. Essentially, a Padua score of 4 or higher would translate into high risk. You can see what goes into the calculation, and of course, there is an online calculator that you can use. And because as of this recording, the CHEST guidelines has not been updated since 2012 for VTE prophylaxis in non-surgical hospitalized patients, there is the 2018 ASH guidelines, and here are the 4 recommendations for VTE prophylaxis. So in acutely ill medical patients, the panel suggests using unfractionated heparin or low molecular weight heparin or fondaparinux rather than no parenteral anticoagulant. The panel suggests using low molecular weight heparin or fondaparinux rather than unfractionated heparin, and in critically ill medical patients, the panel suggests using low molecular weight heparin over unfractionated heparin. And in acutely ill hospitalized medical patients, the panel recommends using low molecular weight heparin over DUAX for VTE prophylaxis. We looked at the results of a specimen stain and listed the most likely organisms present in the specimen. We described the basic process of microbiology testing. We identified the normal human flora and the role in infectious diseases. And we explained the antimicrobial stewardship process for initiating, monitoring, and streamlining effective and safe antimicrobial therapy. Now let's define sepsis and septic shock and explain the cascade of inflammatory and hemodynamic changes that drive organ dysfunction. Now let's take a look at definition of sepsis and septic shock. Sepsis is recognized as a syndrome of acute organ dysfunction due to a dysregulated host response to infection. Traditional sepsis 1 and 2 definitions required presence of infection plus the SIRS criteria. There are a few different definitions of sepsis, and with the latest sepsis 3 definition, which was published in 2016, they switched from SIRS to SOFA, and so that's essentially presence of infection plus a 2 SOFA point increase from baseline. And for most people without chronic disease, it's assumed that the SOFA score is 0 at baseline before the development of sepsis. So if you see a score of 2, you assume there is a 2-point increase from 0, and that will meet the definition. But however, keep in mind that if someone has chronic disease, especially kidney disease and liver disease, their SOFA score may already be elevated at baseline. So you are looking for an at least 2-point increase from baseline. Now, one thing to note is that without infection, you cannot have sepsis. So the presence of infection is a requirement for definition of sepsis. Now, septic shock is a subset of sepsis cases where despite adequate fluid resuscitation, patients have hypotension requiring vasopressors to maintain a MAP of 65 millimeters of mercury and have an elevated serum lactate of more than 2. So it has to meet both requirements of vasopressors such as norepinephrine, and lactate has to be at least 2. In other words, if someone is requiring vasopressors to maintain a MAP of 65 but their lactate is 1, they do not meet the definition of septic shock. Now, so not everybody with infection will develop sepsis, but the subset of persons with infection will develop sepsis. And not everybody with sepsis will develop septic shock, but the subset of patients with sepsis will develop septic shock. And of course, not everybody with septic shock will die, but a good portion of people who develop septic shock are at risk of mortality despite adequate treatment. Now here's another way to look at it. So you can see that here we are looking at a Venn diagram. So not everybody with infection has sepsis, but the subset of infection has sepsis. But also consider organ dysfunction. So patients may have organ dysfunction, which is essentially what a SOFA score increase of 2 points will tell you. But organ dysfunction is not always due to infection. So it could be due to other causes. That's why the presence of an infection is required for the definition of sepsis. So once you have a SOFA score increase of 2 points plus an infection, you have sepsis. And of course, a subset of those patients who require vasopressors to maintain MAP of 65 with a lactate of 2 meet the definition of septic shock. Now, the 2026 Surviving Sepsis Campaign guidelines introduced a few definitions. One is definite sepsis. So this is where sepsis is confirmed based on history, clinical examination, and diagnostic testing, and an alternative diagnosis is very unlikely. They also introduced the concept of probable sepsis. This is where you have a high suspicion for sepsis, but it's not proven. So sepsis is most likely diagnosis based on history, clinical examination, and diagnostic testing, and alternative diagnosis is less likely. But possible. The next definition is possible sepsis. This is where your confidence essentially goes lower. So you have moderate suspicion for sepsis. So sepsis is a possible diagnosis. However, an alternative diagnosis is also likely based on history, clinical examination, and diagnostic testing. And there is unlikely sepsis. This is where you have very low suspicion for sepsis. Clinical assessment is not consistent with sepsis, or an alternative diagnosis is more likely based on history, clinical examination, and diagnostic testing. In other words, Diagnosis of sepsis is not, black and white, where you just have certain lab values or an SOFA score and you can, essentially diagnose it. So there is some degree of uncertainty that requires careful clinical judgment for diagnosis. Now let's take a look at the SIRS criteria. So to date, even though sepsis 1 and 2 definitions rely on SIRS, SIRS is very commonly used for screening of sepsis. So if you meet 2 of these 4 criteria, we say SIRS positive. So the first one is temperature of, so essentially a fever. 38 degrees centigrade or Celsius is the definition of fever, which translates to 100.4 degrees Fahrenheit. So essentially you should have these numbers memorized. If you see a temperature of 38 degrees Celsius or 100.4 degrees Fahrenheit, that's the definition of fever. And definition of fever gets more complicated. If this is, this should probably last an hour, but in the setting of sepsis, it's just a single reading. Alternatively, if somebody has a hypothermia, so low temperature, less than 36 degrees Celsius or 96.8 degrees Fahrenheit. And then heart rate of more than 90 beats per minute is the second criterion. The third one is respiratory rate of more than 20 or PaCO2 of less than 32. So more commonly, we will have the respiratory rate available in the patient chart. Elevated white blood cell count, more than 12,000. Or if somebody's white blood cell is depleted, so if it's less than 4,000, that's one criteria. And along with it, because I said there are 4, 1, 2, 3, 4, so this last one is part of the fourth one. If you have more than 10% immature band, so essentially, if your body is trying to make too many white blood cells very quickly because of the turnover, you will have unusually high level of immature bands because your bodies are making too many white blood cells. So that's another thing that if it's positive meets one of the 4 criteria. Now, of course, the definition of sepsis relies on SOFA. So here's what's in the SOFA, and this is just FYI. Do not memorize this table. There are online calculators you can use to calculate SOFA, but you should be comfortable calculating SIRS on the spot. So the first one is respiration. So we look at PF ratio. PF ratio is the ratio of PaO2. So this is the partial of oxygen in the arteries to FiO2. FiO2 is the fraction of inspired oxygen. So normally it should be that ratio, PF ratio should be at least 400. If someone had respiratory dysfunction, this number tends to decline, and the lower it is, the more severe respiratory, at some point it will be respiratory failure. Then coagulation, so platelets should be normally more than 150. Once it drops under 150, you start to get scores of SOFA. Liver disease, you can see based on bilirubin, you can get different scores based on MAP, how low the MAP is and how much, vasopressors you need. Different points are granted. The same with GCS, so Glasgow Coma scale score, and of course renal. So creatinine of less than 1.2 will give you a score of 0, and then as serum creatinine goes up, then you get higher score, and that's how you get the SOFA score. So as I mentioned previously, for most people, the baseline SOFA is considered to be 0. So once you see a SOFA score of 2, that's positive. But you can easily imagine when you look at these numbers that if someone has advanced cirrhosis, for example, at baseline before they develop sepsis, their platelet will most likely be under 150. Their bilirubin may be elevated, so their SOFA score will not be 0. Or if someone has kidney disease, you can imagine that their SOFA score will not be 0 at baseline. So you should always look for at least a 2-point increase from baseline. And here are some of the recommendations from 2026 Surviving Sepsis Campaign Guidelines. These numbers just reflect the number of, so this is like the 4th recommendation in the guideline, because I'm not going to discuss every recommendation. I'm just showing you the number in case you wanted to look into the guideline to see, to read more details about this recommendation. So one thing that I want to share with you is that for acutely ill patients in hospital, we recommend using news NU2, Muse, or SERS over QSOFA as a single tool to screen for sepsis. Now, sepsis 3 definition introduced the QSOFA score. The reason I'm showing you this definition is that they're just saying don't use QSOFA for screening, and that's why I didn't show you QSOFA because the guidelines say don't use. Now, I'm also not showing you what Muse, NU2, and Muse are because they are less frequently used. SERS is most frequently used, so I showed you the SERS. But you can look up the other ones in case you go into critical care pharmacotherapy. Number 5 is sepsis is a clinical diagnosis and should not be ruled in or ruled out using a single biomarker or diagnostic test. And number 7 is for adults with possible, probable, or definitive sepsis or septic shock, we recommend collecting blood cultures as soon as possible and ideally before the administration of antimicrobial therapy, which is consistent what we learned about microbiology lab. Now, major organ system to monitor sepsis because we talk about organ dysfunction. So these are the organs. So of course the cardiovascular system, and this is where hemodynamic instability comes in. And then we have the liver. So we have hepatic system that can have dysfunction. We have the kidneys, so the renal system. We have neurological system, so altered mentation is a concern. Of course, respiratory system, as people will have oxygenation issues, and hematological system where, for example, there is coagulation issues, platelet count issues, and so forth. Now, the core of the pathophysiology of sepsis is twofold. On the one hand, there is pro-inflammatory response. So essentially, in the acute setting, inflammation is a defensive mechanism for the body when fighting infection. And then on the other side of it, there is somewhat immunosuppression involved with this patient. So there are two things going on, when we look at the big picture, and there's pros and cons of each. So for example, the pro-inflammatory response, the benefits of it is that there is local activation of defensin and cytokines to fight infection. There's activation of phagocytosis and killing of cells, local endothelial activation for increased cell recruitment. On the downside, there is systemic cytokine release with endothelial activation and hypotension. So essentially, these make the vasculature leaky. So as fluids leak out, blood pressure can drop, which is can be detrimental. Systemic activation of complement, dissemination of intravascular coagulation, and organ dysfunction. And then on the immunosuppression side, the beneficial side is that there is regulation and control of inflammation, because too much inflammation can cause damage. So this immunosuppression is going to calm things down, calm down the storm, and increase in tissue repair. The downside of that is that now you have immunosuppression, so people are more prone to getting other infections. So not necessarily the infection that caused sepsis, but now that you're going to have opportunistic infections that can be problematic in these patients. So when you look at the timeline of as the patient's sepsis develops early on, there will be systemic inflammation that can lead to organ failure. So you have some early mortality as a result of that. So this happens within hours. And then as as the body struggles to balance the pro-inflammation and anti-inflammation to maintain homeostasis, there is ongoing immunosuppression that can result in delayed mortality, which happens over the next few days. And then, of course, there are longer-term consequences. So, weeks or months to follow as the patient, even gets discharged from the hospital. There could be a long-term mortality, which can make overall mortality up to 50 to 70%. So this is a very, serious condition. And again, every individual responds differently because there are many factors that determine how a single individual responds to infections. So, for example, age has a factor, comorbidities, if the people have other viruses in their body, how good their microbiota is, And of course, the treatment, did they get the right treatment? Did they receive other interventions? These all affect essentially how these outcomes unfold in different patients. And when you consider all of this, so in this picture, we're looking at the end result in the human body. And this is important because as pharmacists, we need to adjust medications in this patient. So, if you look at this timeline, so when the insult, which is the infection, comes and there's a cytokine storm, so this is the body's immune response to the infection. And then there's the effect on various organs, so the liver, neutrophils, lymphocytes, endothelium, cardiovascular system. And the changes that occur, for example, in the GI tract, there is impaired motility. So essentially, if things are moving slowly, absorption could be impaired. So if you're thinking of oral medications, for example, they may not be appropriate because they may not be absorbed immediately in these patients. There is changes in blood flow. There is capillary leakage. There is changes in protein binding. And because of that, distribution of drugs, so volume of distribution will be different in these patients. So that, all of that affects dosing of certain medications if they are affected by this. Metabolism, so if the liver and if there is hepatic dysfunction and renal dysfunction, metabolism of drugs could be affected depending on a specific drug. If they are metabolized by the liver, so the dose need to be adjusted, or if they are renally cleared, they need to be adjusted. And of course, some of our interventions affects this pharmacokinetics in the patient. So if we're giving a lot of fluids, if there is renal replacement therapy, or if there is ECMO, all of these affect various pharmacokinetic parameters that can affect dosing of agents, and those are extremely important to keep in mind for us as pharmacists. That concludes this presentations. Make sure to like and subscribe. Until next time, take care.